Okay, well, thank you for everybody for coming. My name is Michael Jaffe. I am an associate professor and chief of surgery of the small animal surgery department at Mississippi State University College of Veterinary Medicine. And today I'm going to talk to you about perianal and perineal diseases in small animals. This is a list of some of the things we'll talk about. Anal sacculitis and neoplasia are probably the most common things that we see, but we'll talk about perianal fistulas, rectal prolapses, and the other topics that you see there. Let's start with a brief discussion of the anatomy of the area. The rectum technically begins at the pelvic inlet and ends at the anal canal. Hence, the external anal sphincter muscle is the caudalmost aspect of the rectum. There are a number of different muscles that support the pelvic diaphragm that surround the rectum, and we'll look at those in a little bit more detail here in a second. The anal canal itself is really only about 1 centimeter long in most average-sized dogs. Looking at the muscles of the perineum, these are the muscles that we're most concerned about here, the levator ani and the coccygeus. These are muscles that are going to become really important to us when we're talking about perineal hernias. The external anal sphincter is the muscle that surrounds the rectum. We're all aware of where the anal sacs are located. Usually at the 5 and 7 o'clock position to the anal opening, and the ducts for those anal sacs are in that same location. The internal obturator muscle is going to be important again to our discussion here in a little bit as we talk about hernias. Let's start with the discussion of the anal sacs. So anal sacculitis is probably the most common disorder that we see with anal sacs. And we don't always know what the cause is. We suspect that there may be an infectious component, but there's typically an inflammatory component as well. In most cases, it's unilateral, but some dogs are just prone and susceptible to bilateral problems, and so it's really not uncommon to have one or both affected. However, when we're dealing with neoplasia, apocrine gland adenocarcinomas is the tumor that's most frequently seen. It's almost entirely unilateral. In fact, I don't know that I've ever seen a case of bilateral neoplasia, but they can occur, and they are reported. They're just very, very rare. So if you do suspect a tumor in one gland, obviously we're always going to check the other. For some reason, female dogs do seem to have this more commonly. But let's start talking with anal sacculitis. And again, German Shepherd dogs are probably the breed that's that we see it most frequently. And it's believed to be because of the location of the anal sacs in German Shepherds. They tend to be a little bit deeper, more in oral direction along the side of the distal rectum or proximal anus than in other breeds. It is believed that anal sacculitis in general is more of an inflammatory cause, but infections and abscesses obviously do occur. Certainly less common in cats, but we do see anal sacculitis in kitties occasionally as well. Again, as far as what causes the infection, well, it is believed to be secondary to an impaction of fecal material in the in the duct, maybe secondary to inflammation that eventually becomes infected. As far as treatment goes, most of the time with typical anal sacculitis, we will treat these conservatively. We'll do manual expression to empty the glands, maybe do some warm compresses to relieve some of the inflammation. Oftentimes we'll infuse the duct with some antibiotics, maybe have some steroids in it, depending on what your preference is as far as treating these. Systemic antibiotics are certainly indicated when we are worried about an infection being present as well. When the gland ruptures or abscesses, at that point we have to get a little bit more aggressive. It usually ruptures externally, and so we do have to treat these as open abscesses with surgical drainage and lavage and systemic antibiotics, and many times these will heal up and close over on their own. But when we're dealing with very chronic anal sacculitis in cases, at that point we recommend elective anal sacculectomy. I don't usually prefer to take anal sacs out when there is an open abscess ongoing at the time. We do prefer to get the abscess under control first. Once everything's healed, then consider going in and doing elective anal sacculectomy. With apocrine gland adenocarcinomas, the thing we always have to look for with these is that there's oftentimes a perineoplastic syndrome associated with these as well. With apocrine gland adenocarcinomas, they are oftentimes diagnosed incidentally, checking anal sacs or doing a rectal exam on an older patient. And what these are going to typically feel like is a very, very small BB or something hard and small present within the anal sac itself. With perineoplastic syndromes, it has been reported in patients up to 90% of the time when we have a tumor there, although personally I think that number is a little bit high. We do see dogs with anal gland adenocarcinomas, and I'm not sure that I see 90% of them with perineoplastic syndromes, but it is something that we do have to be on the lookout for. And so we typically want to look at our blood work for these patients, and what we'll see is an elevated calcium. And this is oftentimes due to a parathyroid hormone protein that is produced in a perineoplastic manner by the tumor cell. So we will see this elevated calcium, we'll see decreased phosphorus. And so prior to treating these patients surgically, we do want to diurese them because there is concern for hypercalcemia in the renal tissue. And in some cases, we'll give them diuretics. But the goal really is then to excise the mass and generally perform chemotherapy on these patients. We also do need to be aware of and look for evidence of metastasis. In one study, more than 50% of these patients that presented at the time of evaluation already had metastatic tumors, and these will typically go to the lungs. They can go liver, spleen, but the lymph nodes is where we typically find those. And so the iliac lymph nodes and even inguinal lymph nodes at times are where we're typically looking for these. The problem with this is that it's very difficult to palpate these at times. Sometimes those lymph nodes are very large and we can feel them on a rectal exam. So oftentimes we recommend doing an abdominal ultrasound to look for lymphadenopathy in these patients, and also evaluate the liver, doing some thoracic radiographs to evaluate the lungs for METs as well. Patients with anal gland adenocarcinoma, survival rates have actually improved over the years. It used to be that the numbers were a lot lower, but a dog with a tumor that was treated surgically and either had radiation or chemotherapy following treatment, the average survival time is about 2 years in general. It used to be a little bit lower, but I think we've gotten better at treating these patients. We also get more aggressive, and so when we do have lymph nodes that are have evidence of metastasis, we do surgically go in after those more aggressively than I think we used to. However, if they do have metastases and they do have elevated calcium with this perineoplastic signs and with metastasis, those are negative prognostic indicators, and so they may lower the survival rates in some of these patients. When we do an anal sacculectomy, there's a couple different techniques. There's basically an open or closed technique, and that really refers to whether we're opening the actual anal sac itself or keeping the sac closed. My personal preference is to do a closed technique. I don't really like opening the sac, be it either for inflammatory causes or certainly with neoplastic causes. Some people like to infuse the gland itself through the duct with a substance that makes it easier to palpate on for them. And again, I leave that up to personal preference and how you typically do these. The problem with doing it as an open anal sacculectomy is there is a higher infection risk. In fact, it's in one study it was looked at, there was a 13 times higher risk of infection. So again, if you're doing open techniques, certainly obviously be careful and make sure that we're covering these patients with antibiotics well and being vigilant for any signs of infection. There are a few structures we do have to be aware of: the caudal rectal artery and nerve and the external anal sphincter. We certainly don't want to do any damage to those structures when we're doing the procedure. Post-operatively, we want to keep these patients on systemic antibiotics, whether it's for treatment for a neoplasia or for the inflammatory disorders or for an infection. We certainly need to make sure we're keeping the incision clean, and it does require after each bowel movement until sutures are removed that the owner does blot the incision area with a moist towel or a paper towel or some way to keep the incision clean on a daily basis. In my opinion, e-collars are mandatory in these patients, and in fact, I tell owners 24/7 until even until a couple days after the sutures come out. I want to make sure that our patients are not licking and chewing at that area, because we're already dealing with a potentially area where infection rates are considerably higher than other areas because of the proximity to the anus and rectum. So in my opinion, anything that we can do to minimize infection, and certainly an e-collar is an easy way to do that, is certainly important. I do like to put these patients on stool softeners for a few days. Basically, I don't want these patients having a watery stool. I want them to have a stool that I describe as a toothpaste-like consistency, a stool that's not difficult for the patient to pass, such as a hard stool, and that they're not going to strain, because even with a soft stool or with diarrhea, patients will strain. But with a toothpaste-like consistency, it is a stool that they pass very easily, easy to clean up, and it doesn't cause much straining in the location. Let's talk about perianal fistulas now. And again, this is something that is seen fairly frequently, and it used to be something that was always referred to surgeons, and I'm very happy to say now that we don't get to see these anymore, and we send those to either our dermatologists or our internists. And I honestly, as a surgeon, do not miss doing surgery on perianal fistulas. These are usually single or multiple ulcerated sinuses or fistulae. In my experience, they're usually multiple fistulae that we see. They're usually chronic, and they are typically progressive. This is a condition that does get worse over time and can linger for a very long time. It oftentimes begins as a sterile fistula, but oftentimes these open sores, because of their location to the colon and rectum, do become secondarily infected. It is believed to be of an immune-mediated etiology, and again, that's why I'm very glad as a surgeon to not have to do surgery on these anymore. And the reason why I have this picture of the iceberg here is because what we see on the surface, these open draining tracts and fistulas, is really the tip of the iceberg, because what we see underneath the skin in the deeper tissues around the rectum are very, very large, thickened, scarred areas with open draining tracts. And so when we used to do surgery on these all the time, we had a good appreciation for just how extensive these lesions actually are. But the small fistulas that you may see on the surface of the skin are much, much larger draining tracts and lesions underneath the skin. German Shepherds, unfortunately, are one of the breeds that seem to have a higher incidence of problems with this, and it's really unclear why. It may be an immune-mediated problem at this point. Certainly German Shepherds are known to have other immune-mediated diseases, so it may be a component of that. And as I mentioned earlier, with German Shepherds, their anal sacs are located in a different location a little bit deeper than other breeds, so it may be that they're developing fistulae secondary to anal sacculitis or infections of the anal sac that turn into this. It's also reported commonly in Irish setters. There is a belief that intact males may have a higher incidence, and we typically see this in middle-aged dogs. Again, as far as the pathophysiology, we don't really know what the cause is. Anatomically, it used to be believed that dogs with very broad-based, thick, large tails may be predisposed to it because the belief was that they did not have good airflow to the area around the perineum, and that made them susceptible to infections. But that's kind of been debunked at this point because, again, it is more than likely an immune-mediated problem. These lesions do occur in the location, as you can see in this picture, where the anal sacs happen to be. So again, there were concerns that it may be the anal sacs may be causing the underlying problem, but again, it may be a component of it. But again, the belief really at this point is that this is an immune-mediated problem, and infections and endocrine underlying problems have also been evaluated with these patients as well. So again, we think it's an immune-mediated problem. We don't know that for sure, but we treat it as if it's an immune-mediated disease. Histopathologically, the reason why we think it's immune-mediated is because the histopath lesions are very similar to Crohn's disease in people, which is an immune-mediated disorder. And what pathologists are seeing, they're seeing a lot of lymphoid plasma cells and eosinophils in the tissue surrounding these lesions. There is some suspicion that it may be related to a food allergy. But over time, as we've treated these patients with immunosuppressive drugs and gotten a very good positive response, it lends more credence to the immune-mediated etiology. Now, as far as diagnosis goes, typically what we're going to see are fistulous tracts in the perineum and the tissue surrounding the opening of the anus. Owners will describe these patients as straining to defecate. They may see blood in the stool, frank blood in the stool. On rectal exam, what we will feel is very thick, fibrous tissue in the tissue surrounding the anus and rectum. The skin around the opening of the anus and in the perineal region will oftentimes have these open, bloody, draining lesions that are characteristic of this disorder. There's oftentimes a lot of discharge. Sometimes it's serosanguinous, sometimes it's purulent, and other times it's just frank blood. These patients are very, very painful on palpation and manipulation around the rectum, and they really will resist rectal exams on these. Unfortunately, these poor dogs are very, very, very painful. And there may be some blood in the stools that owners are seeing, and other times they may be constipated or in some cases have diarrhea. So a variety of different clinical signs that owners will note. As far as medical management, again, we use immunosuppressive drugs for this. Cyclosporine seems to be the drug of choice at this point, and it actually does seem to have a very high efficacy in terms of treating these patients. We do like to do a CBC on these patients pre-treatment because, again, we are doing immunosuppressive therapy, and we want to observe for any other occult infections that may be present. The dosage of cyclosporine we put these patients on is 3 to 5 milligrams per kilogram twice a day. And basically what I do with these patients is after a week of starting treatment, I will do blood levels. In fact, cyclosporine trough levels. So essentially, because we're giving the drug twice a day, when the medication is due for a treatment, say if we're giving it at 7 a.m. and 7 p.m., I will draw blood prior to that one of those treatments, so maybe at 7 a.m. before we give the next dosage of medication. And my goal is to try to get blood levels at the trough, at the lowest point when they're due for medication, somewhere between 100 and 300 nanograms per mil. And if I'm getting a dose that's either too low or too high, then I'll adjust my dosage of cyclosporine at that point. Typically, we'll put these patients on an 8-week course to start, but we may have to repeat that 8 weeks if we don't see resolution of signs or if it does recur. And again, based on the blood levels, we may adjust our dosage. Unfortunately, cyclosporine can be pretty expensive. So to try to minimize the cost and try to minimize the amount of immunosuppressive drugs we're giving to these patients, we sometimes will treat them with ketoconazole. And the reason why ketoconazole is used is because the enzyme that breaks down cyclosporine is also it breaks down ketoconazole. And so if we kind of overwhelm that cytochrome P450 enzyme in the liver, it won't break cyclosporine down as quickly, and the blood levels will last a little bit longer in the body. So at that point, we can give them lower doses of the cyclosporine, and ketoconazole is generally safely handled by these patients. The dosage that you see here for ketoconazole is what's typically given. As far as other treatment, we like to clip and clean the area around the perineum and the tail so that owners can keep them clean. We sometimes will wrap the tail if they're having a lot of discharge. I always put these patients on pain medications initially until these lesions heal, because this is a pretty painful problem. And unfortunately, with medical management, we see recurrence in anywhere from a quarter to a third of these patients. There are other options for medical management, which are probably not as effective, with the assumption that this may be due to food allergies. We can put these patients on hypoallergenic diet. Rather than cyclosporine, people have tried prednisone starting with a high dose for 2 to 4 weeks and then gradually tapering. Again, we're using it as an immunosuppressive dose, so there will be side effects with prednisone of the PUPD and things that we typically think of. A lot of times we will put these patients on sulfasalazine as well. And the rule of thirds means that with this type of therapy, with prednisone and a hypoallergenic diet treatment, a third of the patients will respond to it. A third of the patients won't respond, but certainly won't get worse. And a third of the patients get worse despite it. So really, the likelihood that this type of therapy is going to work for these patients is actually low. So in my opinion, cyclosporine is the recommended treatment of choice. Now, sometimes we will see a pretty complete response, but there may be some small fistulae that are present, or if we're catching this very early in the disease where we have very tiny fistulae, we can treat topically with tacrolimus ointment. 0.1% tacrolimus ointment is administered topically to these open fistulae, and we actually see a fairly good response to this. This is not the primary treatment for these patients, but it's really more of an adjunctive treatment, or after we've done a full course of cyclosporine, if we still have a couple of very, very small lesions to clean up, we may use tacrolimus ointment for some of those recurrent lesions. Surgical management is generally not recommended anymore, and again, pretty much only indicated for resistant cases that are resistant to treatment, where they have underlying infections, and we may need to excise or clean up any abscesses that may be present. But really, these cases are kind of few and far between. And in your notes, I included some information about some of the other treatments which we no longer do. A lot of we used to do cryosurgery or chemical cauterization, and for a while there, when it was believed to be due to thick, heavy tails, people were amputating these poor dogs' tails in hopes of treating these, and unfortunately that didn't work. Most of these treatments, the surgical management treatments, are really not that effective, but pain medications for any of these are indicated. But in terms of debridement of these lesions, again, we may do an open debridement and treatment of some of these infected abscess lesions. That's typically after patients who have tried immunosuppressive therapy, maybe once, maybe twice, and it's failed. We may have to go in surgically and open up and debride some of these. But again, there are a lot of side effects. There is a concern about causing some fecal incontinence in some of these areas. We may have to do anal sacculectomies in conjunction. And unfortunately, the recurrence rate with surgery is higher than it is with cyclosporine. So in these cases, again, medical management is certainly preferred. As I mentioned, chemical cauterization with topical substances such as, treatment with tacrolimus is not really chemical cauterization, but it used to be that, again, we would use some iodine or other forms of treatment to kind of ablate the open draining tracts. It was pretty painful for these patients. It could cause some incontinence. Silver nitrate was also used, and it burned these poor dogs. So this is, again, something that's no longer recommended. All right, let's switch and talk about anal and rectal prolapses. This is something that is more commonly seen in young dogs, I think, but you can see it in any age dog, and we may have a partial prolapse or a complete, and we'll talk about how to diagnose those here in a little bit. But suffice to say that this is usually secondary to straining to defecate for one reason or another. Again, it's more common in young dogs. And the reason being is because there's oftentimes predisposing factors such as parasites. And again, it's important to do a good fecal exam on these patients and or treat them for internal parasites, looking for evidence of other GI problems such as colitis or ticlitis, older patients that may have neoplasia who strain to defecate, or patients with foreign bodies or even viral enteritises like parvo may result in prolapse. We may also see it in patients with other disorders such as a perineal hernia where they're straining to defecate, or a severe cystitis. Older male dogs with prostatic disease, we may see these, or it could occur secondary to dystocia in a breeding female. As far as diagnosis goes, we need to try to diagnose whether or not this is a prolapse or a true intussusception of the colon and rectum. And to do that, we will pass a lubricated blunt probe along the side of the tissue that's prolapsed and against the wall of the anus. If it's an intussusception, it's going to pass. The probe's going to pass pretty easily, pretty far up. But if it is just a prolapse of the anus or rectum, the probe doesn't pass, and it's certainly a little bit easier to treat in that regard. For something like an intussusception, it may require an abdominal procedure to go in and do an enteroplication and to reduce the intussusception. As far as treating the prolapses, though, first goal is to try to reduce the prolapse, and oftentimes we need to lubricate this tissue with saline. We may also use some sterile KY jelly, something along those lines. We will use 50% dextrose topically if the tissue is severely edematous, and that will help decrease some of the edema. There are reports of people using systemic furosemide to try to decrease edema, although that's not something I typically do. Usually just manual compression or treating with 50% dextrose will get the tissue and the edema out in a sufficient manner to reduce the prolapse. Once it's reduced, then we'll treat it with a purse string suture as illustrated on the right. And again, a purse string is placed and usually kept in place for about a week. We want to leave an opening that's about the diameter of our small finger, maybe depending on the size of the patient. But we do have to leave enough of an opening so that they can continue to pass stool, but won't prolapse. So again, we have to be careful that we don't over tighten these things. And we're going to leave that in place about a week. Then we're going to remove the purse string and observe for whether or not they reprolapse or not. And if they do, we may have to purse string them a little bit longer or do another procedure such as colopexy. While they're on, while we're treating them, we want to put them on a low residue diet. We want to keep their stool fairly soft, so we're going to put them on lactulose because, again, we want them to be able to pass feces easily. And we may use a topical local anesthetic in that area where the purse string is, and I always put an e-collar on these patients as well. If the tissue is severely damaged, if it's been out a long time or the patient may have chewed at it or it's lost its blood supply, then we may have to do a rectal resection and anastomosis. And basically what that involves is cutting away the tissue that is sticking out and then resuturing it back to its healthy self, and then reducing the prolapse and putting a purse string in there. If there is a recurrent prolapse, then we may have to do an abdominal procedure called a colopexy. And just like a gastropexy for GDV dogs attaches the stomach to the body wall, a colopexy does the same with the colon to the body wall. And this is generally indicated for recurrent prolapses or ones that just don't resolve with conservative management such as a purse string. But basically, once we reduce the prolapse, we go into the abdomen and we put some tension on the colon, and we do a partial thickness incision in the colon and a partial thickness incision in the body wall on the left side of the abdomen where the descending colon lives. And we're going to use some sutures to basically create a pexy of the colon to the body wall. In general, we have to be careful with this that we don't pass our suture through full thickness into the colon because that could potentially cause an abscess at that location. We generally use monofilament non-absorbable suture to create a permanent pexy. There's something small, usually 3/0 or 4/0 suture, and it's just a small double line of simple continuous, just like for a gastropexy. And after colopexy, recurrence of the prolapse is pretty uncommon. Let's talk about perineal hernias now. This is actually one of the more common perineal disorders that we do see. And this is generally due to failure of the muscles that form the pelvic diaphragm along the rectal wall. And again, what we typically see when a perineal hernia occurs is the hernial contents are usually just fat. But they can be some of the abdominal contents. In fact, the most common abdominal organ that herniates into a perineal hernia is the urinary bladder. And if that's the case, then that may necessitate more of an urgent surgery than if it's just fat that's herniated through there. What owners will sometimes note is that the hernia is large, and then after the patient urinates, that the hernia gets smaller, and then through the day it seems to get bigger again, and they urinate and it gets smaller, and that's an indication that the bladder may be in the hernia. Radiographs taken of the caudal abdomen may demonstrate the bladder, and if you still can't find the bladder, we can always catheterize these patients and pass some contrast material into the bladder and try to localize where the bladder may be. It's pretty uncommon that the bladder does herniate into the hernia, and when it does herniate, it's pretty uncommon that it actually entraps. But the bladder may be present in up to 25% of the cases of perineal hernias. This drawing is a little bit confusing, but again, kind of the muscles that we talked about earlier. It's these two muscles here, number 1 and 2, the levator ani and the coccygeus muscles. These are the ones that usually atrophy or break down that result in herniation. The external anal sphincter, number 13 here, is along the wall of that pelvic diaphragm, and the muscle along the bottom here, number 4, the internal obturator. We're going to use that muscle to help us repair this hernia in many cases. As far as the etiology, it's usually middle-aged to older male dogs, certainly much more common in male dogs, and it's typically in intact male dogs. And so it leads us to believe that there may be a component of either endocrine component or secondary to prostatic enlargement or prostatitis that may occur in these patients that result in straining and the hernia forming. It's very unusual to see an isolated left-sided hernia. If we're seeing a unilateral hernia, it is almost exclusively on the right side, and nobody knows why that is. But the right side of the perineum is the more common location for a unilateral hernia, but more than half the cases that we see are bilateral hernias. So again, when we palpate a hernia on the right, we always be really careful and check on the left side, and it's by rectal exam that we'll feel a diversion of the rectal wall into the hernia, and we won't be able to palpate that pelvic diaphragm. Most of the time, what we're seeing is a deterioration or atrophy of the muscles. And again, it's likely due to a hormonal influence that we see these, and it's due to the presence of androgens that cause the atrophy of these muscles. But as I said, it could be also due to prostatomegaly. Perineal hernias in cats are not very common, but they can occur. But certainly in dogs, intact male dogs that are older is pretty much the poster child for this. But we will see it in kitties. And when we see it in a cat, it's usually secondary to something else, such as obstipation, maybe from megacolon or strangury, or a cat that has urinary crystals and may necessitate a PU surgery, something that causes them to strain that may result in breakdown of the muscular diaphragm and cause the hernia to occur. Cats, curiously, don't have a sacrotuberous ligament, and the sacrotuberous ligament in dogs runs along the same location as the levator ani and the coccygeus muscle, but cats don't have that, and we will sometimes use that sacrotuberous ligaments in dogs to help us repair the hernia. We do have to be careful because the sciatic nerve runs very close to it, so if we can avoid that using that ligament, then certainly that's to our advantage in causing less potential complications. As far as clinical signs go, these patients usually present with a large firm swelling in the area in the perineum surrounding the anus or the rectum. It usually deviates a little bit more ventrally. It's usually pretty edematous, and it feels like there may be fluid present in there. These patients usually present also with a history of straining to defecate, some obstipation or tenesmus. Owners oftentimes will report that their stools look very thin or small as they're straining. Some of these patients may be incontinent. When we palpate them, we will feel a sacculation or a deviation of the rectal wall towards the side of the hernia. And again, in intact male dogs that are older, we have to double check the prostate and make sure that that's healthy as well, because we will see prostatomegaly in almost half of these cases. And again, as I mentioned before, be aware that the bladder may retroflex. Conservative management of these cases will actually alleviate signs for a very long period of time, but it doesn't take the hernia away. Typically, people have treated these with enemas when these patients are constipated or obstipated. They'll put them on high-fiber diets to try to promote the stool moving through easier with laxatives. In some cases where they become fecally obstructed, it may necessitate sedating them and doing a manual evacuation of the colon. And like I said, it alleviates some of the signs for these patients, but doesn't really fix the problem. Preoperatively, I always take a caudal abdominal lateral radiograph because, again, I'm looking for the bladder. I want to know where the urinary bladder is. And in this patient, it is in its normal location, but you can see this large amount of fecal material that has formed underneath the tail in the location where the hernia happens to be. But again, I'm also making sure I'm not missing something else that's herniated in there, and I'm looking for evidence that there may be a tumor or an enlarged prostate in these patients as well. We may also do an ultrasound of the abdomen. If it's an older patient, we are looking for potential causes for this um, other than them being an older intact male. Again, we're looking for any evidence of neoplasia or other underlying disorders that may cause this. And if we can't find the urinary bladder, we may pass a urinary catheter or do a contrast study. Surgically, there's two pretty common techniques for fixing these. It's the standard technique where we're basically suturing all the muscles back together, or an internal obturator muscle flap where we dissect out the internal obturator muscle and we flip it over, and it basically covers up the area where the hernia was, and we suture that to the muscles. And that's my treatment of choice. That's how I typically fix perineal hernias. In some cases, we may have to do some mesh or some prosthetic implants in there to cover up the hernial site. And in severe cases, we may have to even take the superficial gluteal muscle and transpose either that or the semitendinosus muscles to cover up these defects. But one of the most important things that we can do for these patients, if they are intact male dogs, is to castrate them. Because again, one of the underlying causes for the muscle atrophy is due to androgens present in the system, and by neutering them, it takes those away after about 2 months, but it decreases the likelihood that the muscle is going to continue to atrophy and cause recurrence. If the urinary bladder is retroflex there and keeps wanting to flip back up, we can do even a cystopexy. If the colon is, if the rectum is prolapsing, we may even have to do a colopexy in some of these cases as well. As I said, with the internal obturator flap, what we do is we make an incision over the hernial sac. The hernial sac is usually fluid-filled. It almost looks like there's some momentum that's in there typically. And once we open that, there's usually some fluid that's present, but most commonly we see omentum and abdominal fat. And so reducing it is pretty easy. Once we make our incisions, we can pretty much push everything back into the abdomen, and then we can evaluate the musculature around the perineal diaphragm. So the pelvic diaphragm muscles, again, we're going to look at the levator ani and the coccygeus, and depending on how much muscle is still there, determine how we're going to fix this. If those muscles are still pretty beefy and thick, then we may do a standard repair where we just basically sew all the muscles back together. But typically these muscles are atrophied, and in those cases we have to do an internal obturator muscle flap. And if all the muscles are really atrophied, including the internal obturator, then we'll put a piece of mesh in there, or we'll use that to bolster it. Complications from the surgery can occur. Recurrence is probably the number one complications. Whatever caused the atrophy of the muscles, that disorder may continue to progress, and it may cause a breakdown in the repair due to further muscle atrophy. And it's been reported up to 50% of these can recur long term. To be honest with you, I think that 50% number is a very, very high number. We don't see that many recurrences. I would say more in the order of maybe about 10% or less, I think, would recur. By castrating them, we reduce that likelihood of recurrence. Infection in that area is a concern, again, because of our incision that's present along the area of the anus and rectum. Incontinence can be an issue, so we have to be very careful that we're avoiding the nerves, that neurovascular structures that go through that area, and the likelihood of incontinence is very, very low. Some of these patients may continue to strain to defecate for a period of time, and which could result in prolapse, and other things such as sciatic nerve paralysis if the sacrotuberous ligament cause some entrapment with our sutures. With that, those and some urinary tract problems may occur, but those are certainly less common. Post-operatively, we do put these patients on a laxative, something like Metamucil or lactulose. But again, where our goal is to achieve a toothpaste-like consistency, we don't want these patients straining to defecate from stool being too firm or straining because they have diarrhea. Again, we want a very easy to pass stool for them. And I'll probably keep them on a laxative in this case for at least a month, maybe even more, because I really want this to scar down. Certainly keeping the incisions clean, having owners clean them after bowel movements and at least daily. We want to limit their activity because, again, we don't want them running or jumping. That's going to cause a breakdown in the repair here. I typically do put these patients on broad-spectrum antibiotics post-operatively, treating for gram-negative, so I like Clavamox for these patients post-op. We may manipulate their diet again to achieve a looser, a softer stool, and then e-collar again, just like with anal sacculectomy, in my opinion, is absolutely mandatory. If we have to revise these due to recurrence, we may either resuture our original sutures, depending on what we find. If I did a traditional repair or standard repair and I still have my internal obturator muscle, I may use that for revision to flap it. I may have to incorporate the sacral tuberous ligament or one of the other muscles, or I may end up putting mesh implants in, where basically we put the mesh in, as you can see here, and we suture it to all the muscles around it, and it forms a wall to prevent the recurrence of the hernia. Let's talk a little bit about anal tumors. These are probably one of the more common problems that we see. Perianal adenomas are probably the most common ones, and again, these are benign masses that form around the rectum. They can be a little bit challenging to remove because they're usually at the mucosal surface of the rectum, and so it's very hard to remove these, and there's always a concern about causing some incontinence or bleeding. These are typically seen in older intact male dogs, and we do need to do some cytology on these prior to surgery, because if it's an adenocarcinoma, then we have to plan our surgery a little bit differently, because we'll have to take very wide margins of tissue at that point. We may see perianal adenomas in other locations along the perineum, even down by the prepuce or the inguinal or the thigh regions. They're characterized as very slow growing. They're usually single, but they may be multiple, and they can ulcerate and bleed. Adenocarcinomas are definitely less common. Adenomas are certainly more common. And then there can be the other tumor types that we'll see around the in the perineal region as well. The treatment of choice is surgical excision. If I know that I'm going after an adenoma or something benign, because of the location with the rectum, I may do a little bit more of a marginal excision where I'm not taking wide margins, but I do want to completely remove the mass and preserve the mucosal tissue, because again, I don't want to cause any strictures around the anus. If it is a malignancy, well, then we have to plan a much more invasive, larger surgery. And so again, it's important to know what we're getting into before we remove these. Certainly mast cell tumors we see in this region as well, and it becomes challenging because we do have to take wide margins for those. If it's an intact male dog, we do recommend castration in these cases, because again, there is a higher predisposition in intact male dogs, so there may be a factor that's associated with that. If it is an adenocarcinoma, then we have to fully stage these patients with thoracic radiographs and abdominal ultrasound as well. And then if it is an adenocarcinoma, we have to talk to the owners about adjunctive treatments such as radiation or chemotherapy. When we have intrarectal tumors, these are usually benign. Adenomatous polyps are certainly the most common ones, but we will see some carcinomas or other tumor types. Malignant tumors within the rectum, within the rectal wall can occur. Adenocarcinomas are the most common that appear there. And again, older male dogs are the breeds that are the segment that we see this most frequently in. To diagnose these, owners will usually note that their pet is straining to defecate. There may be some blood in the stools or maybe mucoid feces. There's typically some frank bleeding that's associated with polyps, and they may be painful when they're defecating if there's a larger tumor in the wall of the rectum. Physical exam, our rectal exam is going to be important, certainly observing for any blood on our glove after doing a rectal exam and palpating the rectal wall, checking the prostate, all those things. Like I said, abdominal radiographs and ultrasound are valuable in these cases to rule out other neoplastic causes. Colonoscopy is real valuable. If you're able to do that, you might be able to get a biopsy, and so you'll know in advance, are we dealing with a carcinoma or something benign, and then thoracic radiographs to rule out any metastasis. As far as treatment goes, surgery to remove the masses is indicated. Preoperative antibiotics, because we're working in a dirty area for all these, is going to be important. And again, we want to pick something that has good efficacy against gram-negative bacteria, and certainly some of the second-generation cephalosporins are going to be valuable for that. I don't typically do enemas or give laxatives in these patients preoperatively because it does tend to make the feces very watery and it becomes hard to work with. So I would rather deal with a more solid stool that I can clean out easier manually than dealing with continuous runny stools. When we have polyps, we do a procedure called a rectal eversion, where we basically kind of grab the mucosa around the polyp and evert it externally. We don't make any skin incisions. Once the polyp is visible, then we do kind of a little cut and sew technique where we remove the mass sequentially, and while we suture up the mucosa, these polyps are generally confined to the superficial layers of the mucosa, and so we don't have to typically do full thickness excisions. If we're dealing with a much more invasive mass, well, then we may have to do a more invasive surgical approach, such as a rectal pull-through or an abdominal approach, or even splitting the pelvis to have to get down to the rectal wall, which is certainly not a pleasant thing for these patients. As far as complications of these mass removals, we do worry about dehiscence and infections in these areas. Anything along the mucosal surface of the anus and rectum, we worry about strictures or certainly infections there. With tumors around the perineum, we do worry about incontinence and certainly recurrence or metastasis for any malignancy. As far as the aftercare, again, we are going to treat these patients with stool softeners. Again, I'm looking for that toothpaste consistency again. Something that's going to reduce straining and make it easy for the pet to have a bowel movement. Regardless of whether I have made a skin incision or if I've done a eversion technique, I do place an e-collar on these patients because they do tend to lick quite a bit back at that area. And so again, anything we can do to keep that area clean and minimize any chance of infection, we're going to take advantage of. We always put these patients on broad spectrum antibiotics, and again, it's the gram negatives that we're choosing our antibiotics specifically for. It's not uncommon for some of these patients to have a little bit of hematemesia for a few days, so they may see some frank blood in the stools after a polyp removal. And again, even though I don't have any sutures in the mucosa when I remove polyps, I like to do a recheck rectal exam on these patients 10 to 14 days. Now, a lot of these patients do get recurrence of these rectal polyps, and just like rectal polyps in some people will recur, people have to have them removed by colonoscopy every few years. We do see patients where every few years they develop another rectal polyp. So again, I don't know what the underlying cause of that is, but we do see some patients where we do see recurrence of these. The last thing I'm just going to mention briefly is anal rectal strictures, and these are usually due to trauma. These oftentimes may be secondary to surgery in that area to remove large masses. They could be due to foreign bodies that have passed. They could be due to neoplasia or infections. These are very difficult to treat. These do require either treatment by bouginage, where we're gradually trying to stretch the anal rectal tissue, or by something real aggressive like a rectal pull-through technique. Probably one of my least favorite surgeries in the world to do, simply because there is a very high incidence of incontinence, fecal incontinence in these patients. Dehiscence is a very big concern, as is infection. But for a patient that has a stricture and can't defecate, this may be their only option. And it really is limited to the very, very distal rectal masses. Despite all the problems and complications and the unsavory nature of this surgery, it actually does work. And so owners do have to understand that there may be a fecal incontinence issue associated with this before we go into the surgery. So I thank you for your attention. I'm happy to answer any questions you may have. Here's my email if you'd like to email me with any of your questions, and here's our hospital's phone number. And again, I thank you for your attention.